How do you diagnose this condition? You need to have the gold standard, which is the nasopharyngeal swab for a polymerase chain reaction. Now, this test detects the genetic element in the virus, which confirms the infection. It is believed that lower respiratory samples may have a higher sensitivity. The nasopharyngeal swab has a sensitivity of about 70%. If you do a sputum specimen, that could be about 80%. And if you do a bronchoalveolar lavage, almost 90% of cases are picked up. This PCR can be done either as an isolated PCR, or we also have the gene expert machine, which can also be used with less chances of contamination in detecting this infection. Sequencing is not routinely used. We also have serological studies, both antibody tests and antigen tests. So far, they still lack sensitivity and probably specificity. The serological tests are useful if they are done 2 weeks after the onset of symptoms. So in the early phase, they may not be positive. And the antigen tests currently available through nasopharyngeal swab is also not very sensitive, but we are now working on them to improve the sensitivity of these tests. Viral culture, which remains positive for only 7 to 8 days after the onset of the infection, is not routinely available. You need biosafety level 3, and it may not be possible to commercially do it for all cases. As I mentioned earlier, the various positivity rate, depending on whether it is sputum or bronchoalveolar lavage, is shown here. The nasal swab is around 60 to 70%. The sputum is about 70 to 80%. Bronchoalveolar lavage is more specific. 1% of blood and almost 30% of fecal samples show positivity for PCR, which shows that the genetic material of this virus is picked up. But what impact this has in transmission is still not clear. The laboratory findings may include, like other viral infections, leukopenia, lymphopenia, thrombocytopenia, serum calcitonin, which is procalcitonin, which is normal, raised D-dimer, and other markers of inflammation like CRP, LDH, D-dimers, and ferritin can all be elevated. The chest X-ray, especially if done after a week of symptoms, may show patchy peripheral infiltrates, which may take up to 10 to 12 days to become worse. The CT scan shows patchy ground glass opacities, and this may progress on to a crazy pavement pattern. In children, you get a reversed halo sign also. Ultrasound may show non-specific findings, and this sometimes, when used with the clinical picture, may help in diagnosing COVID-19. These are images of chest X-ray showing somebody who has gone on into developing ARDS. The X-ray, these are the early changes. You'll see peripheral ground glass opacities in a patchy fashion, and then they go on to develop a crazy pavement picture, and then subsequently features of ARDS. It is believed that the case fatality rate in young people is much lower. Experts feel that the case fatality rate in people under the age of 60 can be less than 1% in fact. But as you grow older, the complications and risk of dying increase to be as high as 15% in patients over the age of 80. It is also believed that underlying comorbidities like cardiovascular disease, diabetes, hypertension, chronic respiratory, especially structural lung disease and cancer, increase the risk of complications and mortality. So when do you suspect that somebody could have the disease? During times of pandemic, anybody presenting with fever which is unexplained or other features of respiratory involvement, you need to think of a possibility of COVID. Typically, people who have traveled abroad, which now is unlikely because of the lockdown, at least in several countries, contacts of confirmed cases, asymptomatic people of confirmed cases, household members, healthcare personnel, and anybody who's hospitalized with severe acute respiratory illness should be suspected to have the COVID-19 infection. In spite of several advances in the last few months, it is surprising that we still don't have any definitive therapy in managing patients with COVID. Except paracetamol, acetaminophen, and oxygen, there is no other definitive drug which has been unequivocally recommended as a choice of treatment. Isolation, rest, hydration, monitoring the patient, giving oxygen if there is hypoxia, again, measuring both blood and biochemical indices and care of comorbidities still form the basic support in treating these patients. In mild cases, apart from monitoring the patient can be kept at home in isolation, and symptomatic treatment for the fever and pain is what is recommended. People who are moderately unwell, who may develop hypoxia, where the oxygen saturation falls to less than 94%, may require hospitalization. These people need blood tests including CRP, D-dimer, ferritin, and also monitoring of the neutrophil lymphocyte ratio, the NLR, which is basically the ratio of absolute neutrophil count divided by the absolute lymphocyte count expressed in a percentage. If it is more than 3.13, that indicates a poor prognosis, because that means that the person has significant lymphopenia. I shall mention about the role of other drugs subsequently. Severe cases need oxygen support. You can start off with supplemental oxygen through the nasal cannula, then the face mask, then a rebreathing mask. This may proceed on to high flow nasal oxygen and then non-invasive ventilation. The idea is to maintain saturations above 90%, in the region of 90 to 96%. If we cannot maintain it, sometimes even with awake proning using NIV or high flow nasal oxygen, mechanical ventilation after intubation is recommended. It has been seen people who end up on the ventilator have poor prognosis. So as much as possible, we try to avoid the ventilator and try to supplement oxygen through other ways, and specifically, as I said, by positional changes, lying on the side, lying prone, procedures which may recruit the alveoli and improve oxygenation. There have been several drugs which have been tried. Initially, chloroquine and hydroxychloroquine, which block the viral entry and endocytosis in the cell, were used, but studies have subsequently shown that the side effects of these are very high and they did not show any benefit. Similarly, azithromycin alone or with hydroxychloroquine was used in the early phases. They have found to be not useful in handling these infections. There have been several antivirals which have been tried, mainly agents which were useful when tried out against the SARS-CoV-1 during the epidemic 2 decades ago. Anti-HIV drugs including lopinavir, ritonavir and darunavir, ritonavir initially showed some promise, but subsequently they have fallen off the grid. Oseltamivir is anti-influenza drug, has no role. Favipiravir, initially again used by Japan in the treatment of flu, is also showing probable benefit in mild and moderate cases, but a very little evidence is there. The drug, mainly the antiviral, which is showing probably some promise, is remdesivir. Remdesivir is generally indicated during the early phase within 10 days of onset of symptoms in people who require oxygen but have not yet gone on to require mechanical ventilation. There has been a decrease in the number of days to recovery and probably a trend towards lesser mortality. It is believed that the immune response of the body in COVID, in SARS coronavirus 2 infection is a little different when compared to certain other viruses. It is believed that the body is tempted or tricked into going through the lymphoid pathway to increase the cytokine response to battle this virus. And sometimes there is a cytokine dysregulation leading to a cytokine storm, which causes an increased number of pro-inflammatory cytokines to be exhibited by the body, which can cause systemic inflammatory response and a multi-organ failure. So steroids have been recently shown through the recovery study that a dexamethasone of 6 milligrams per day used in patients who are requiring an increasing oxygen support probably helps in mitigating the rapidity of escalation of the infection and also has a mortality benefit. Tocilizumab, which is an anti-interleukin 6 inhibitor, also seems to have a role to play, especially in people who are ending up in a cytokine storm. Interferon alpha has been used, but still has not shown much promise. We are still looking at plasma, convalescent plasma treatment to see whether it makes a difference. Studies are still on. Because there is a procoagulant tendency where there is minute clots formed in the smaller blood vessels, especially of the lungs, which may contribute to worsening hypoxia, anticoagulant therapy is now being used. Prophylactic low molecular weight heparin has been found to be useful in preventing complications. Some of them end up with deep venous thrombosis and pulmonary embolism, where therapeutic anticoagulation is recommended. The WHO has now strongly come back on discouraging the use of hydroxychloroquine in the management of COVID patients. As I mentioned, the cytokine storm usually happens in the second week when the person goes into a pro-inflammatory overdrive. And as I mentioned before, interleukin-6 antagonists, along with other agents, especially the JAK kinase inhibitors, baricitinib and other agents, are now being tried to see whether they will make a difference. The coronavirus is now behaving more and more like the HIV virus. It is believed that it is able to trick the human host and probably, respond or intervene differently in stimulating the immune system. So we are looking at different ways to look at treating this infection, maybe a combination of drugs, maybe combining antivirals with anti-inflammatory agents. But whatever it appears, because it probably hastens the way an older patient responds to infection, the mortality is much higher in elderly patients. What is more interesting now is probably looking at ways to boost the normal immunity of a person to see whether we can use the body's normal immunity to fight this infection. It is believed that antiviral immunity is the key to recovery from COVID, and by ensuring that the healthy immune system fights off the infection, especially using vitamins, micronutrients, and essential amino acids, we may probably look at better outcomes in handling patients, especially the elderly and the malnourished. So in these lines, there are several agents which have been considered. Vitamin C has always been an important vitamin which plays a role in especially viral infections of the respiratory tract. It is believed that the vitamin C upregulates NK cell activity and has a role to play as an essential antioxidant in managing infections. There is a close association between vitamin C and the antiviral response against several viruses, which is now being considered as important in fighting COVID also. Vitamin B also is very important. The group of vitamins play an important role against fighting several infections. And it has also been shown that when there is the deficiency of these vitamins, the response is weaker and the prognosis poorer. It is not only vitamins, but we are also looking at trace elements. We have always known that elements like selenium, copper, and magnesium are an important part of a person's immune fight against infections. In fact, copper as a material has been very clearly shown to have antiviral properties even when used in the as a surface coating as part of infection control in several hospitals. So now we are now going back to seeing whether by ensuring that we correct the deficiencies in these trace elements, whether the response in fighting infections like COVID will have a more important role in the therapy. Zinc is also an agent which has a lot of close correlation with antiviral immunity. There have been a lot of studies in the past where it has been shown that zinc is very important in fighting infection, and the deficiency of zinc leads to impaired immune responses. So these are now being strongly considered. There is also evidence that zinc can inhibit coronaviruses. Even though there is a lot of material still coming up, there is no definite evidence so far to say that high doses of zinc or these elements make a difference. But this is a very interesting field which shows there is a lot of potential for the role of these elements. There is also a protective mechanism of zinc in COVID. It is believed that it improves the mucociliary clearance of the upper respiratory tract. It also limits infection through interferon alpha production. There is also an inhibition in bacterial and viral multiplication in the presence of zinc. Apart from zinc and other vitamins and trace elements, essential amino acids are also an important part of our fight against COVID-19. During COVID, there is a significant catabolism. The body pains which are associated and the protein breakdown which happens with COVID necessitates a diet which is rich in essential amino acids. We also have evidence to say that essential amino acids are important in several immune responses, including the production of cytokines, gene expression, oxidation and reduction, proliferation of lymphocytes, and activation of certain lymphoid lineages. So, since we are in a situation where we don't have definitive specific treatment in battling the COVID-19, people are looking now at these aspects to ensure that we can optimize outcome. Lastly, there is another important aspect of managing patients with COVID-19. Since this is a virus which is spread through respiratory route and is highly infectious, we need to set in place a good infection control program in hospitals, especially to keep the healthcare workers safe and to ensure that other patients are also protected. The infection prevention and control aspects of managing patients with COVID start with the triaging at the outpatient or emergency services. It is recommended that all healthcare workers wear personal protective equipment in the form of a surgical mask and keep at least a distance of 1 to 2 meters between patients, especially when they are suspected. Patients are also strongly encouraged, if they can tolerate, to wear a surgical mask. In general, a triple layered surgical or a medical mask is protective enough unless aerosol inducing procedures are being undertaken, in which case an N95 is warranted. Eye protection is also recommended where you anticipate the possibility of splashing of respiratory secretions on the face. So a face visor or goggles is recommended. When airborne precautions like sampling a patient for nasopharyngeal swab, nebulization, cough induction, intubation, extubation, any of these is done, then you need to wear, apart from the face shield, an N95 mask and a gown also. Contact precautions are also recommended because, similar to the flu, these viruses can also be transmitted through fomites, and dedicated stethoscopes and blood pressure apparatus are required. Most importantly, to ensure that there is, in case of aerosolized viruses, the ventilation has to be adequate and the airflow has to be adequate so that these are cleared when a patient is housed in a room who's COVID positive. Hand hygiene, as the World Health Organization says, is probably the most important aspect of infection control. The WHO has come up with the 5 moments of hand hygiene: before touching a patient, after touching a patient, before an aseptic procedure, after a procedure, and after coming into contact with the patient's immediate environment. These are the 5 moments when hand hygiene is strongly recommended. If your hands are soiled, you need to use water and soap. Otherwise, just using an alcohol sanitizer is appropriate. It is also very important that healthcare workers are educated on the appropriateness and the correct way to don and doff personal protective equipment. When handling patients who are in the ward, either in the ICU or in the ward, appropriate personal protective equipment includes the wearing of a gown, a mask, a triple layered or an N95 mask, goggles or face shield, and gloves. But what is more important is that they should be taught the technique of appropriate doffing of personal protective equipment so that they don't contaminate themselves during the process of doffing. Environmental disinfection is also a very important part of infection control in the times of COVID. Since this is an enveloped virus, it is very easily destroyed with alcohol or with bleach. A 0.1% solution of sodium hypochlorite would suffice to clean most areas. Sometimes toilets and ambulances may require a higher concentration of 1%. It is also believed that those instruments, or for example the cell phones or blood pressure apparatus which may be corroded by bleach, one needs to use a 70% alcohol solution. This would be good enough to clean these contaminated surfaces and instruments, and that will also help block the further transmission of the infection. So in summary, we have to accept that the COVID is here. It is unlikely that we are going to get rid of it in the coming weeks. There is a possibility this may run for several months, if not years. There is a strong possibility, even if we get this controlled at this point, that we may have a second wave or a third wave, which already they are facing in China. To face this, we need to have in place clear knowledge about how to fight this. We are evolving therapeutic techniques to ensure that we get rid of the virus, starting off from antivirals and immunomodulators. We are now focusing on the importance of enhancing normal immunity or natural immunity by using amino acid supplements, zinc, and vitamin supplements. Lastly, infection control is a very important part. Physical distancing, universal masking, hand hygiene, and cough etiquette probably will form the fundamental pillars in keeping us and our patients safe. Thank you very much.